Hello, I'll be presenting on enhanced recovery after surgery, also known as ERAS. Our objectives are to recognize the need for the ERAS protocol, be able to describe the ERAS elements, and utilize ERAS elements in the clinical practice. To give a background, 1 of 4 people having an operation will experience a complication. Over 22,000 members had an operation at LAMC in 2017. Here's some pictures of how an operation could look like. Up to 50% had complications, which could be UTI, sepsis, infection, bile leak, pneumonia, abscess, bleeding, fluid overload, ileus, and those are just some complications. Because of the high numbers of complication, there is a need to reduce complications and improve outcomes. This is why we implemented the ERAS protocol. So what is ERAS? ERAS helps the patient get better faster. And how do we do that? With multimodal preoperative care pathways designed to reduce physiological stress, improve recovery, reduce complications. It is also evidence-based practice and patient-centered. ERAS is characterized by a whole team involvement, along with auditing for compliance and measuring outcomes. Key elements of ERAS includes pre-op counseling, optimal nutrition, cessation of tobacco and alcohol use, no NPO after midnight, but with carb load 2 hours prior to surgery, standard anesthetic management, multimodal analgesia, VTE prophylaxis, early PO intake, and early ambulation. The benefits for ERAS is basically better outcomes. It was reduced complication of 50% fewer, shorter hospital stays by 30%, and it helped a lot with decreasing costs. There are different benefits for ERAS, and we have 4 different elements. One is a pre-op carbohydrate drink, and the benefits for that was avoid starvation, dehydration, patient satisfaction, decrease nausea and vomiting, keep the gut stimulated, prevent muscle weaknesses, and decrease insulin resistance. Multimodal analgesia benefits were improved pain control, minimize narcotics, decrease risk for delirium and nausea and vomiting, decrease risk for post-operative illness. For early ambulation, the benefits were decrease the risk for deep vein thrombosis and pulmonary embolism, decrease the risk for pre-operative pneumonia and post-preoperative ileus. Early nutrition, it stimulated the gut, decreased postoperative ileus, return to normal physiology, and shorter length of stay. The patient population for ERAS is basically anyone having elective surgeries. Adults and pediatric patients who presented for elective general, orthopedic, gynecologic, urologic, vascular, plastic, neurologic, or head and neck procedures. This does not currently include patients undergoing most emergent procedures, patients under the age of 14, as well as elective cardiac surgery patients. We have an enhanced recovery checklist. As you can see, it starts from pre-op to intra-op, goes to PACU, and then inpatient nursing. Our focus is for inpatient nursing is early feeding, ambulating or mobility, and multiple multimodal analgesia, or antiemetics. So how will we meet our goals? You must be able to identify these patients and place them in our hospital ERAS list. Each of the four metrics and or interventions for your patients must be documented 12 hours out of time that the patient leaves the operating room. And that includes liquid adherence, early feeding, ambulation mobility, and multimodal analgesia. This is how the ERAS workflow looks like. In PACU, the ward clerk by 7 in the morning sends out a daily list of patients that will be having surgery. In the units, our leaders will then add those patients into the Health Connect for ERAS intervention monitoring. REOP has their role of making sure they document NPO status. The physician also place orders for ERAS. The PACU RNs, if they have those patients, they will then um, start the ERAS elements. If they are able to, they will provide the ice chips or water, assist the patient to ambulate, and also upon giving report, let the inpatient nurse know when the OR exit time was. And if they can, start the multimodal um, pain management on the more. For inpatient, the surgical patient will arrive and we should place a laminated E that has the OR exit time located on there, so that everyone would know that the patient had just had surgery and we need to complete the elements within 12 hours. Of course, documentation, and then once the 12-hour mark hits, we can take those laminates down. For patient outcome, um, they have been auditing our patients that are in ERAS, and they will look at the documentations of the NPO status, early feeding, diets, and ambulation. They also can notify the nurse if they are doing great or if they need to have any corrections um, of the charts. So here are some of the orders that you may see in Health Connect. One order can look like clear liquids after midnight. Another one could be NPO accept meds. And another one could be communication. So if the patient will be having surgery, they can continue to have they can be NPO after they get their carb drink. So no indications of the carb drink. They can be given an 8 to 12 ounce of carbohydrate supplement drink 2 hours prior to surgery. And they must consume that within 15 minutes. But for diabetic or delayed gastric emptying for previous bariatric surgery patients, we can give 8 to 12 ounces of water 2 hours prior to surgery, and that must be consumed within 15 minutes. So some of the carb drinks include Gatorade or Powerade, apple juice, Clear Fast, Gatorade Prime, and of course for our diabetic patients or delayed gastric emptying is the water. One thing we must document is once the patient is NPO. So for inpatient, if you had given the supplement or the carbohydrate drink after that 15 minutes they consumed it, we must place that they're NPO. And please make sure you document that. For early feeding intake, we want to make sure that we document on nourish given, whether it's lunch, dinner, breakfast, or snack. And we need to make sure we place the diet percentage taken, whether they've completed or had the whole snack or any other percentage. Documentation required on multimodal analgesia. We just want to make sure that um, there is at least 3 multimodal analgesia medications and that they are ordered for the patient, and you just want to make sure you document what medication you gave to the patient. For ambulation and mobility, there are 3 sections that you must document. One is the activity management, the distant walked, and activity assistance provided. One thing that we would want you to address is making sure that you assess your patient before you can get them out of bed. Um, and this is a quick tool assessment, making sure that they can move their upper extremities. If they're able to do that, their lower extremities, then you can actually get them to the side of the bed or dingle on the side of the bed. Have them take a couple of breaths. If they're not wavering off, you can actually try to see if they can lift their legs up. Um, uh, and if they're able to have strength on their legs, then you can actually have them stand. I highly suggest that you have a walker in front of the patient so they can grab on something while they stand. And if they are not able to stand or they buckle, you can actually place them back into bed. But have them stand up with a walker and then they can pivot and transfer the chair. Or if they're able to, you can have them walk a little bit in their room. So exclusions for the criteria for ERAS. One is the dietary intake. If the patient has an order for NPO or an NG tube is in place, we don't have the ERAS for that. And then of course for ambulation, if the patient's baseline mobility is a level 1 or 2. One way you can find out the OR exit time is you can look in the event management in Health Connect. You can place the MRN of the patient, and then you can go to encounters events and patient out of the room, and it will let you know what time the patient had ended their surgery. And this is how the green E looks like, and you would place the exit OR time there. So this concludes my presentation on ERAS. Takeaways are providing carbohydrate supplements 2 hours prior to surgery if ordered, documenting NPO time, post-surgery identifying the OR exit time, and documenting the completion of the 4 ERAS elements of liquid adherence, early feeding, ambulation and mobility, and multimodal analgesics. Thank you.